My name is Paul Ferguson. I'm a clinical lecturer in haematology. I'm employed by the University of Birmingham and I work at the Queen Elizabeth Hospital in Birmingham at the Centre for Clinical Haematology. Here at ASH 2015, I gave an oral presentation on a study that we performed in conjunction with the UK NCRI AML working group. Essentially, it was looking at a proportion of patients with acute myeloid leukemia who have what we term primary refractory disease. Essentially, these are patients for whose outcomes with conventional chemotherapeutic strategies are very inferior. These patients have very poor survival outcomes in the longer term. What's been interesting is the fact that despite the fact that we've known these patients do so poorly with treatment for such a long period of time, we actually don't have a consensus definition of what constitutes primary refractory acute myeloid leukemia, and this has really hindered us in terms of trying to develop strategies or studies to look at how we approach the problem and how we try and improve our therapies. So what we did was we looked at almost 9,000 patients who were treated on the UK NCRI AML trials from 1998 all the way through to 2010. And what we looked at was trying to identify, using various parameters of how a patient responds to treatment, to try and see whether we could actually identify these patients much earlier in their treatment pathway. And that's essentially what we've done. And so where it's been conventional for patients to have 2 courses of chemotherapy, and then at that point to realize that actually this patient is doing very badly, and then you're trying and find some sort of salvage strategy to save the patient's life. Actually, what we've done is we've actually found a way of trying to classify at least half of these patients after 1 course of induction chemotherapy, and that can have a very significant impact on, first of all, how we then look at how we stratify these patients going forward, and also how we think about how we step in with alternative therapies, be that salvage chemotherapy or be that allogeneic stem cell transplant at that point in time. What's also interesting from the work that we've done is that not only have we identified patients after 2 courses of induction chemotherapy, but we've also identified these patients for whom allogeneic stem cell transplantation offers the only realistic hope of long-term survival. And so by doing that, we've actually been able to, allows us to think about looking at transplant strategies going forward, and by applying these criteria to actually think about designing trials or studies to try and address the problem of how to maximize the therapeutic potential of allogeneic stem cell transplant in this very difficult patient cohort, to try and maximize patient overall survival and long-term survival. I think first of all, how we identify them is we looked at previous studies looking at outcomes in patients with acute myeloid leukemia treated with conventional induction chemotherapy, and looking at the parameters that they set in terms of how a patient responded to that initial cycle of chemotherapy and what their long-term outcomes were. And it became very clear to us that there were 2 studies in particular that allowed us to, if you like, set a gate for, or set parameters that we could start building various criteria. And we actually used 4 varying criteria of response to that first cycle of induction chemotherapy, and from that we were able to tease out those 2 important cohorts that do much worse than the other patients. Going forward, how that will impact on terms of patient care, I think at this point in time it's still experimental, and in the sense that what it does allow us to do is firstly to identify these patients early, and that means that then you can start looking at your treatment strategies earlier in the patient pathway, albeit you've saved the patient an additional course of quite difficult induction chemotherapy with morbidity and mortality associated with that, and you can think about alternative strategies. But what you will be allowed to do is take the criteria that we've defined and actually hopefully start to look on clinical trials to try and build a more coherent strategy to try and develop better therapies for these very difficult patients with primary refractory AML.